Discuss with the neonatal complications. So what is going to happen to the neonate in the case of diabetic mother? Okay, so this is a part 3. Okay, so the neonatal hypoglycemia may happen sometime. Neonatal hypoglycemia because in the mother there is already more glucose, so because of that there will be more insulin secretion in the in the mother. More glucose means even in the fetus more glucose, so because of that fetus will start producing more insulin and that will lead to neonatal hypoglycemia. And another condition may be hypocalcemia. Okay, hypocalcemia will be seen in neonates. And hypokalemia, so low potassium, low calcium, low magnesium, hypomagnesia. So all the important nutrients are missing in the fetus now. In the neonate. And also RDS. So what is RDS? Let me see. That is neonatal respiratory distress. Okay, neonatal respiratory distress also can be seen because all these nutrients are low, and already I discussed that placenta will have hydrop edema placenta, so low oxygen coming to the baby. Okay, and hyperviscosity syndrome. What is this? Hyperviscosity syndrome. Whereas in this hyperviscosity syndrome, you'll see polycythemia. Okay, polycythemia and also bilirubinemia. Okay, that is bile is very high, polycythemia, cell has become very big, hyperviscosity, this blood has become more viscous. Okay, and also there is other complication, HOCM, that is myocardial cardiomyopathy, which is reversible. Okay, hypertrophy cardiomyopathy, okay, which is reversible. And increased chances of dislocation, especially most common is shoulder dislocation is common here. Okay, why we know already. Okay, and fractures, clavicle fracture is most common. And due to macrosomia, clavicle fracture is due to macrosomia. And even you can see the shoulder dislocation is because of macrosomia. During delivery time, because of the drag, there may be shoulder dislocation. Okay, next coming to maternal complications. So because of diabetes, what is going to happen to the mother during pregnancy? Okay, so now let us see that maternal complications are like increased chances of abortion in mother because of diabetes. Okay, are seen especially in overt diabetes, that is already who are having pre-gestational diabetes. Okay, and there is a cause of polyhydroamines. Okay, in the mother, more because of more glucose, more renal blood flow, more GFR, more urine, that leads to more polyhydroamines, right? And polyhydroamines can also lead to preterm labor. Okay, it can lead to preterm labor, we already know this. It can lead to premature rupture of membranes, it will lead to postpartum hemorrhage, it will lead to abruptio placenta. So these all can be seen mainly because of polyhydroamines. And the next one is there is increased size of placenta, so there is increased PIH. Okay, increased placenta means increased hypertension, okay, in the mother. And increased chances of infection, also more infection chances are there, like asymptomatic, or you can say bacteriuria and urinary tract infection, UTI. Okay, these are seen in the chances of infection. And increased type 2 diabetes, because mother has, if she have gestational diabetes, she may have chance to get type 2 diabetes in later life, like about 50% of female have type 2 diabetes. So all women with gestational diabetes, 6 weeks after delivery do again. So again after 6 weeks of diabetes we need to do OGTT, that is oral glucose, 75 grams of glucose, 2 hours test, right? So how many times we need to do diabetes test? First in the antenatal, in the first antenatal visit we need to do one. Between 24 to 28 weeks, that is during that 24 to 28 time, we need to do one. And again after 6 weeks of pregnancy we need to do one, because we need to see whether the gestational diabetes is continuing or it has stopped. If it will continue, mostly it will continue in 50% of female has type 2 diabetes. Okay, so what is the management of diabetes? How to manage this? Okay, so the management is for the case of overt diabetes, that is overt, right? Already they are having from the beginning. As soon as pregnancy diagnosed in an early diagnosed case or diagnosis is made by 2 hour OGTT, okay. Sometimes some female may don't know that she is already having diabetes. Okay, in some female come to know exactly during pregnancy because of this 2 hour GTT test. Okay, so diagnosis is made by this, and if this GTT is greater than 200, sure she is having already over diabetes. So the patient is of course put on insulin to prevent the gross congenital anomalies in the baby. So there is no role of any diet modification in oral hypoglycemic drugs. So remember, in the over diabetes we don't give any oral drugs, and also we don't give any diet modification in them because they're already having diabetes from the beginning. Okay, but in the case of gestational diabetes, when we do DIPSI, we do this GTT. If it is greater than 140, it's a gestational diabetes, and now we can do the diet modifications for the 2 weeks, and also we do 2 hour test again, and if it is less than 120, we continue the diet. But if after 2 hours, if it is greater, if the test shows that the blood glucose is greater than 120, then we will start insulin. Like if some, in some gestational diabetes mothers, they will be controlled by means of diet itself. If you do diet and if you do the test, if it is less than 120, then continue the same diet. But even on diet, if they are not getting reduced the diabetes, then we need to start insulin even for them. Okay, so indications for insulin is for the over diabetic patient and 2 hours OGT in the first antenatal visit, right? If it is greater than 200, and gestational diabetic mothers also, if their value is greater than 120 even after diet, then also we need to continue further. So the dose of insulin which is given, dose is 0.7 to 11, sorry, 1 international unit per kg. Okay, so 0.7 to 1. Metabolic goals for insulin treatment. So FPS should be less than 95, and 1 hour PP should be less than 140, 2 hour PP should be less than 120, HbA1c should be less than 6, and capillary glucose should be less than 100. What are these all values? These all values are the target for the pregnant female. This should be the target. These are the values they should have during pregnancy. These are the metabolic goals for insulin treatment. Like the FBS should be less than 95, 1 hour PP should be less than 140, 2 hour PP should be less than 120, HbA1c should be less than 6, average capillary glucose should be less than 100. Okay, and the oral, coming to oral hypoglycemic drugs, they are contraindicated in pregnancy, so we not give oral hypoglycemic drugs. Okay, except we give metformin. Metformin can be given, and also glyburide. That too, this both should be given only to the gestational diabetes mother, not for over diabetes. Metformin and glyburide only given for gestational diabetes mother. Okay, and a patient of gestational refuses insulin, then only you give this. Okay, but in over we can't do anything. Now coming to the time of delivery, never deliver in early term, because already there will be lung will be not formed properly. So never deliver in early term between 37 to 38. Never cross 46. So this is very important. We should never deliver them between 37 or 40 weeks, and also we should never cross 40. We should never cross 37. And the time is controlled on diet and insulin, that is top greater than 39 weeks can go up to 40 weeks. So if even you are controlling on diet on insulin, you can go greater than 39 and up to 40. This should be maximum. We should not go beyond 40, or we should not go less than 39. So what is the mode of delivery? Of course vaginal delivery can be done, but the C-section is done only when expected weight of the fetus. So very important, if the weight of the fetus is more than 4.5 kg, then we need to do only C-section. We can't do vaginal delivery. So finally coming to the insulin therapy during pregnancy. So insulin therapy, give regular insulin, that is especially short acting. Give short acting insulin and NPH insulin. NPH insulin should be given, that is long acting, at bedtime. So very important, short acting at the daytime, long acting at the bedtime. You can also give mixed start insulin, but better to give this short acting NPH. Don't mostly use mixed start. The newest studies also showing ultra short like aspart, ultra short insulin is called aspart and lispro. These are also safe. Ultra short these are, okay. And limited evidence of use of long acting insulin like glargine have limited use. And as the pregnancy advances, the dose of insulin also increases. So that's it. By this we completed diabetes in pregnancy. Next we'll start with hypertension in pregnancy.